A number of people have sent me this video today. The video is of a student explaining her theory as to why schizophrenia happens. First off, I just wanted to say how delighted and excited I am anytime I see a young mind take interest in psychiatry. Disorders of the brain and mind like schizophrenia are some of the most challenging ones that we currently diagnose and treat. We absolutely need more people who are passionate about this work, and I absolutely love that you're continuing this conversation. The student in the video brought up a couple of points about diagnosis, pathophysiology, neurobiology, and treatment, and I'll try to touch a little bit on each of these. First, let's talk about the circuit-level neuroscience of schizophrenia. While there are a whole number of brain regions implicated in schizophrenia, the circuits are maybe a little bit easier to dissect. And I say that because all of the processes we see in schizophrenia, hallucinations, delusions, cognitive impairment, the whole host of negative symptoms, none of these is localized to any one specific brain region. They're all complex interactions of multiple brain regions at some level. Some of the ones I would highlight, like I've highlighted in other videos, are the salience network, which helps the brain filter out what's important and what's not, but also the default mode network, cognitive control, and discrete neurocognitive processes like efference transfer, which allows the body to send to the sensory area what sensations it should expect based on movements, and then collateral discharge, where the sensory area then says, let's not pay attention to that because we know it's just the shirt on the arm because the arm is moving, that type of thing. That's a whole field of PhD study on its own. The student spoke a lot about glucose, and definitely one of the big risks of schizophrenia is an increased risk of cardiometabolic disease, but there's a whole number of reasons why that happens. As you can imagine, if your brain is in a state of psychosis, it's really hard for you to enact really good lifestyle behaviors. So even apart from any underlying genetic predilections for cardiometabolic illness, it's harder to do the things that keep one healthy from that perspective. Which segues us into treatment. The student brought up how antipsychotics don't necessarily cure the underlying cause. However, we know that duration of untreated psychosis is a poor prognostic factor because neurons that fire together wire together. So the longer the brain is in a state of psychosis, the more entrenched it becomes in that firing pattern. So early treatment with antipsychotics is one of the best ways to help someone live the most comfortable and highest quality of life they can achieve regardless of their illness. That being said, antipsychotics pretty much uniformly increase the risk of cardiometabolic disease because of various off-target effects. And oftentimes it's becoming more and more standard of care to start metformin or even a GLP-1 to prevent the weight gain associated with use of drugs like olanzapine or clozapine. However, if those drugs are being started, it's usually because the benefits outweigh the risks. But those are just thoughts, and oftentimes in psychiatry, we don't always know the answer, but we try to create space for healing and help people live the highest quality of life we can. Thank you so much for continuing this important conversation. I look forward to learning more from your ideas in the comments.